I'm Dr. Sameera Rathnayake, consultant obstetrician and gynecologist attached to the Obs and Gyne department, Vayamba University of Sri Lanka. And so we are going to discuss one of the, important topic, so chronic pelvic pain, right? Chronic pelvic pain. I think this topic is why I choose this topic, and this is basically, and in your clinical practice also, you may encounter a lot of patients and with the chronic pelvic pain, and to see the patient with the chronic pelvic pain is very challenging, right? Very challenging because number of reasons. And one thing is that every patient has a story behind. It's not a short story, it is a long story. Another thing is, and so they are seeking the help from the various specialties, and they are coming with the and coming with the handful of clinical records and all. And other thing is, another important thing is, and I'm quite sure that you may have seen this type of patient in your clinical practice as well, and you may not be happy if this type of patient walk through the your window of your door of your clinic, right? So, and important thing is, right, and when you are seeing this patient, they are consuming a lot of time of you all. Lot of time of you all. If you are not giving the adequate time for them, so they are not very happy, right? They are not very happy. And other important consent before going to this to discuss about this topic. So important thing is you should understand the concept of and dynamic nature of the pelvis, right? Dynamic nature of the pelvic functions. When you come to the pelvic, you know that, right? So there are a number, and the pelvic organs is occupied in the pelvis, which are rested on the pelvic floor. And bladder and your reproductive organs and your bowels and everything is there in the pelvis, and they are working always in the dynamic environment with different timelines. And when it comes to the bladder, for example, you know that so bladder is emptying every day, every time, right? So you are emptying the bladder 5 to 6 times per day. So when it comes to the other organs as well, so this function is same, right? This is same, right? So this is very dynamic. This dynamic nature, this dynamic nature of the this dynamic nature of the pelvis is disturbed in somehow with the different pathologies eventually give rise a lot of and clinical symptoms for you all. And with that thing in mind, so we will step into the our presentation, and you can
Oh, oh, ya nag-edit mo ka?
okay, oh, it is not coming. Right. And right. So, and just go through this clinical scenario. You can see the 28-year-old lady and see the severe dysmenorrhea, and for 2 years, and with the dyspareunia, and they comes to you, and sometimes you may arrange the imaging for them, and eventually you will get the report of normal ultrasound scan. So, what do you think about this, right? So, and you may think if your imaging is normal and everything is fine and you don't have any problem, and now you can step out of the clinic, right? So but it is not like that, and these patients are suffering a lot, right? So next thing is just go through this clinical scenario. And 42-year-old lady, she has undergone hysterectomy and self-ingofrectomy, and coming after a couple of years, coming with the chronic pelvic pain. And you arrange the more sophisticated investigation. You are having the MRI, but MRI is normal, and so you may be reassured that you don't have any organic cause for the bleeding. Right. So these are the types of patient you will get when it comes to the chronic pelvic pain. Right. So we everyone has a question. So when these patients are comes to you, and it is challenge for you all, is a definitive challenge, because you will and it's difficult to make them happy with the your whatever the available treatments and all. And so in this lecture, so we are going to talk about couple of few important things. And first thing is definition of the chronic pelvic pain, and understand the current pelvic pain mechanisms, and also recognize the common and uncommon causes, and also develop systematic clinical approach to diagnosis, and also interpret the investigation appropriately and formulate the evidence-based management plan. And so when it comes to the chronic pelvic pain, is a definition is a very simple. Your definition is very simple, and your if the pelvic pain perceived to be pelvis, if it is there for more than 6 months, and is exclusively or not exclusively associated with the menstruation. And also, the biggest problem with this pain is the functional disability. They are, and these patients are mostly affected in terms of their day-to-day life. So you can see the and burden of this problem. If you see the 4 women, so out of that one has this problem, nearly 25%, right? And also another important thing is this is affecting basically for the productive population of the country, right? So nearly the age group between 15 to age between 15 to 50 years. And also, and so this is the one of the, and important cause for gynecological referral, right? Referrals. A lot of referrals we are getting because of chronic pelvic pain. They are regular customers to your clinic, and difficult to treat them as well. It is very challenging. And so when they comes to you, and also, and as they are coming to us regularly, so what will happen is the eventual escape point is doing some invasive investigation, and tell them you don't have anything, and you can we don't have any reason to treat for you. So, and so you can see that it is account for nearly 40% of the gynecological laparoscopy. So we are doing a lot of laparoscopic operations and the diagnostic laparoscopies for due to this reason, right? So mostly for the younger people, and so is the younger people. And other thing is, and so often, right, when it comes to this type of patient, chronic pelvic pain, it is overlooked. We are not, take it much serious when they are comes to us, and because of that reason, is so 50% of them remain undiagnosed, right? Undiagnosed unless you have a very experienced clinician and you look into this, and and in detail causes. And so that. And so when it comes to the this chronic pelvic pain, it has a lot of burden for the that particular patient. And as it is affecting this product, and a very young age, right? Yeah, young age. And so because of this pain, they have a lot of other disturbance to their day-to-day life. So there, and so one thing is psychological involvement. So where you can get the anxiety and depression and the spectrum of disorders, and also they disturb with their sleep, and because of that reason ended up with the chronic fatigue, and also infertility. Also other concern where you can see so this in these patients, and greatly affects their sexual functions because of this is basically, and you are having this problem in the reproductive age group. And also, and so they are, and working force of the country, and also is an affect to their day-to-day work, and poor quality of life, and also absences from their clinical their works as well. So, and this eventually, right? So, and give a lot of burden for the patients, but you all should know how to identify the and symptoms, or else how do we identify the symptoms for the chronic pelvic pain. Most of the time they come and complain you constant pain, right? Constant pain in the pelvis or lower abdomen or pelvis. And also, and it is connected to the your and your all the pelvic functions, functions, when you are urination, when you are opening your bowel, and your sexual functions, and also in when it comes to the reproductive functions also, and showing the infertility and all. And also it's not that all pain, and this pain is disturbed, right? The all the activities, right? All the activities. So, and so when understanding the chronic pelvic pain, right? When understanding the chronic pelvic pain, right? So it's not you should understand is not a just and just some physical pathology, right? Physical pathology. So you should understand the dynamic nature of the and also or else modifiers of the this pain, like your psychological involvement and social factors, rather than considering the underlying single condition. So up to recent past, that. So in terms of chronic pelvic pain, there's no standard classification system or standard classification is there to and go through systematically when you are assessing this type of patient. So because of that reason, in the recent past, and introduced by the FIGO and the International Pelvic Pain Society, the newer classification, what we call are you moving Swami's classification. This is one of the newest classification they have introduced. So with this, right? So when you are seeing the patient, right? So you can systematically assess the patient and according to this standard framework, right? When you are assessing the patient with a chronic pelvic pain. So, and I will go through the this when we see this classification, it is very extensive, right? Which is very extensive, but I'm not going to concentrate all the things. So we are going to concentrate few things which related to the reproductive and reproductive system, right? So you can see that, right? You can see that your reproductive causes are top in the list, right? Top in the list. You can see that. So these reproductive pathologies are the adenomyosis and your uterine fibroids and endometriosis, and also pelvic adhesions, which can be secondary to previous pelvic infections, or else it could be due to previous pelvic surgeries, right? And also right? Chronic PID top in the list. So apart from that, you can see that, and I'll show you, is there are hundred of causes for the chronic pelvic pain, right? Hundred of causes for the chronic pelvic pain. So, and these are the two and categories which relate to the gynecology. And other things, vulvovaginal causes, and due to and mostly due to genitourinary syndrome related to the menopause, and also related to the some entities of vulvodynia and all. And apart from that, that this pelvis is not belongs to the, and gynecologist, right? So it is below sharing with the different teams. Basically, it's a urologist and colorectal surgeons, and number of teams are involving. So you can see that the so reason for the chronic pelvic pain is not always is gynecological, right? So you can see that some GI gastro, and bowel related causes also there, gastrointestinal causes. So commonly out of these things, you can see that irritable bowel syndrome and chronic constipation and also chronic diverticular disease sometimes can cause this type of pain. And also, and other entity is the your urinary causes. So out of these causes, and one of the causes we are dealing with bladder pain syndrome, right? Bladder pain syndrome, and this is basically is poorly identified when the patient comes to you all, and it is difficult to diagnose. A lot of diagnostic challenges there, right? Only in the if you have a awareness regarding these all the things, only you can and meaningfully see the patients and come into conclusion that you are having this problem, right? So apart from that, your vascular. So this is one of the other important condition, pelvic congestion syndrome. I'll show you later on some videos around these things, how this affect your, causing the chronic pelvic pain. So pelvic congestion syndrome or pelvic varices can cause this sometimes this type of vague pain in your lower tummy, and very, and difficult to or else challenge to diagnose. And so apart from that, some so other important thing concept you should understand when it comes to the chronic pelvic pain is a central sensitization. It's not always and your pain stimuli give the pain. So it is modified by effect from the central nerve system. So where you can see this, hyperalgesia, allodynia, and some cognitive problem related to the chronic pelvic pain. And so other thing is your pain is can be related to your musculoskeletal causes, right? So out of this, one of the important things is the pelvic floor dysfunction. Pelvic floor dysfunction. So in this pelvic floor dysfunction, what we can see is there. So pelvic muscle tone is more than the what usual, and more than the usual tone. So because of that reason, this some pelvic pain can be triggered, right? And also some and the joints around the pelvis also give rise in this type of pain. Your sacroiliac joint, your symphysis pubis, and also some muscular and dysfunction as well. And apart from that, so if you are unable to categorize, if the patient comes to you and you have evaluated, you have go through the your standard systematic assessment, and so you may not find sometimes the reason for the pain. So it could be an unexplained pelvic pain where and so your and regional pain syndrome, sometimes fibromyalgia, and those causes will be applied in these scenarios, right? So, and you can see that, and so I don't want to go through all the things. You can see that there are a number of causes, right? Number of causes for this pain, right? So, and other important consent you have to understand when it comes to the chronic pelvic pain is and your pain, is it related to the actual tissue damage or not, right? So actual tissue damage. So, and traditional model is the pain is equal to the your disease process or disease, right? Whatever the physical disease in your pelvis. But when it comes to the chronic pelvic pain, right? So when it comes to the chronic pelvic pain, that your pain is modified by multiple factors, if you input from your nervous system, and psychological factors and social influences as well. So that is a modern model for the your chronic pelvic pain. But this concept also very important. And other thing is when it comes to the pain mechanism, that. So usually pain arising from the your pain receptors, which is related to the nociception, or else the actual neural damage which can give rise the pain. So, but when it comes to the chronic pelvic pain specifically, what I want to highlight is and this is nociplastic or a central sensitized pain, right? So, and very difficult to treat, and so I'll discuss in the and during our treatment discussion, and what are the modalities available. So, and a little bit of information regarding central sensitization, and the pelvic pain. So, once the pelvic pain is there, so there, as it therefore chronically, right? What will happen, and your person is adapt to this pain, right? Adapt to this pain, and somehow you are trying to cope this thing, right? So that so different characteristics are there related to the central, and central sensitization, including your widespread pain, right? So you can see the, and the hyperalgesia, and also in the fatigability, and also, and which is related to your sleep disturbances, and also, and fibromyalgia. And other important thing is pain is no longer reflects your actual tissue damage, right? Pain is not and proportionate to the your tissue damage. That's why it is difficult to treat for this thing, right?
Right.
So when this patient comes to you, it is basically it's a challenge for you, right? It is basically it's a challenge for you, because that when you are starting even treatment, and treatment process, and so and it's difficult to make the diagnosis for this patient. It's a diagnostic challenge is there, right? So, but you are trying to treat with some form of analgesics or different modalities of the analgesics, right? And another thing is, that even you are, and presuming some etiologies, and you are trying to treat them, but still, and and so it is not the correct treatment for them. So they are not improving, and they are coming back again. And other important thing is, so it is multi-modality treatments. Sometimes it would be challenged according to your resource availability in terms of treating them. For example, and so we don't have some of the facilities for treating them. So another thing is, what we should choose the pathway basically, and your treatment goal is to improve their functions, basically pelvic functions, to by improving their and to their the quality of life, right? Quality of life. So that's what should be the our target. And other important thing is, so pain mapping. When this patient comes to you, and pain mapping is very important, mapping the pain. So there are different type of ways of mapping the pain, so that we can do by self mapping and also physical mapping also, and as a doctors, and we can do more advanced mapping during your imaging during the your imaging modalities, or as the during laparoscopy as well. So, and it's important to, and so give some tasks for them as well, and to maintain the pain diary, right? Pain diary is important, where you can give the, and information about the and maintain the, and the pain symptoms according to the daytime, and according to their work related pain and all, right? So pain mapping is important, and concept. So before heading to the treatment, right, or else, and that these patients are difficult to treat, and you may give some simple analgesics or simple, pain relief modalities. So before that, you all should screen for and any alarming features with them. So, or else what we call clinical red flags, you should able to identify. So, and a few, and red flags here. So if the patient is coming with the unexplained weight loss, right? Unexplained weight loss with the chronic pelvic pain, that is alarming. And also, and if they are coming with the postmenopausal bleeding, and also, and always when patient comes to us, so what we used to do is, I'm asking for a couple of questions, and if we are not getting the answers for those questions, and so with our experience, sometimes we are leaving the patient without examining. So, and it's important, the patient comes with the pain, at least you have to keep your hand in the tummy and hand in the abdomen and examine and see for any palpable masses, because we have seen in our practice, so, and a lot of missing cases are there. So, and they are having the multiple seek to the advice or seek the help from the different specialties, but no one has examined. Eventually, they are come with the and the large pelvic masses. And also hematuria. It's one of the important clinical symptom. So where you have to and identify and specifically. And also, and your rectal, if the patient is complaining of rectal bleeding, right? Rectal bleeding, or is associated with evidence of infection, including the fever fever and evidence of infection, and that is alarming. And also, and it's important to and know about if the night disturbances with this pain or history of cancers, right? So, and family history is there. So then you have to and pay more attention when you are making the your diagnostic approach. And when it comes to the investigations, right, when and due in for the patient with the chronic pelvic pain, so investigations are simple, where what you are using every day, right, every day. So, so you can see that. So initially, you can give some simple investigation like pregnancy test and inflammatory markers, urine analysis. So most of the time, exclude the your common problem. But if you are thinking this particular patient is needed, so more advanced assessment, so then you have to refer them for the imaging with the ultrasound scan, and so an MRI, and if needed, then certain specialties will decide on whether they need so more invasive approach with your diagnostic laparoscopy. And so I will discuss couple of investigations which are useful in terms of, and making the diagnosis for the gynecological point of view. So an ultrasound scan. Ultrasound scan is very useful imaging modality for us, right? When you comes to the your and when it comes to the in terms of gynecology, it's adenomyosis and also endometriosis and so on. So, but I would say when it comes to this ultrasound scan, I would say this is one of the most abusing investigation as well, because so we all give the low threshold for the arranging the ultrasound scan for all the patients, sometimes without the idea. So then what they do is, so if the ultrasound scan normal and we are deciding that, okay, so your pelvis is normal, right? Your pelvis is normal, you don't have an organic cause for this pain, and you may leave. So what will happen is, same patient is going to the different specialty again and again seeking the help because of this unsorted problem with her, right? So but we can use ultrasound scan very useful way, and very useful way, and though it is and generally considered as ultrasound scan normal, and that we can't say that means normal ultrasound scan and is and does not equal to the, and it's a normal pelvis, right? Normal pelvis, that is a key message, right? Key message. So and if you're if and so if experienced person is doing the ultrasound scan, can gather a lot of information, so more than your traditional assessment just to see the screening for the pelvic organ, right? So even when it comes to the adenomyosis, you can make the make the and more suspicion on your ultrasound scan, and also in terms of your, so obviously diagnosis is histological assessment, but you can come into the conclusion that with the ultrasonic features you adenomyosis, and also endometriosis, right? Endometriosis. So though your ultrasound scan is sensitive imaging modality for ultrasound, and the diagnosing of the endometriosis, if it is there, your large and and the cyst or masses is there in the pelvis, but sometimes even endometriosis are there. So in the so superficial endometriosis specifically, and your ultrasound scan is absolutely normal, but the patient is still having the same problem of endometriosis, And so when it comes to the MRI, so that is also more sophisticated investigation, uh, which is and available for us, but we are not encouraging very frequently to going forward with this thing, very expensive, and also and and resource limitation. However, this is a very important investigation when it comes to the diagnosis of these type of and diseases, right? So, and is there any, and help of going forward with doing the laparoscopy or diagnostic laparoscopy? So, and if the patient is repeatedly coming to us, if the patient is repeatedly coming to us, and and sometimes headache for you all as well, and by looking at these patients when they come to the clinic, sometimes that there's no and treatment you can give at this point. So, and that's what the general impression you are having. And so, if so, only what we can do is escape, is giving some more advanced or more invasive assessment, and assessment for them, and you can tell that your everything is normal. But more than that, right? So keep in mind, and so your imaging modalities, even it is normal, right? Even your ultrasound scan normal, and still some benefits of going forward with the laparoscopy, where you can see the disease and you can and come into the diagnosis, come into the some conclusion that this patient is having this problem, sometimes pelvic adhesion, sometimes pelvic inflammatory disease, and sometimes superficial endometriosis which can cause the pain, right? Like that you can see sometimes your pelvic varices and these type of things. And also, and it is a treatment modality. At the same time you are making the diagnosis, you can do the some treatment as well. If the adhesions are there, you can do the adhesiolysis, and you can treat for the endometriosis, and also, and certainly for the your other pelvic pathologies as well. And another important thing is, there are a lot of limitations when it comes to the laparoscopy, and resource limitation. One of the things, and everywhere is not available this facility, and also and even disease is there sometimes, and it's challenging to treat for them as well. For example, endometriosis. So it is and I will show you in the later on in your in our videos, and how disturbing and to the pelvic functions and some disease like endometriosis. Another thing is, so even you do the laparoscopy and so think that laparoscopy is negative, can you 100% say that this patient is all right? So no, so still you can't say that. So you can't say that. So and you can't 100% reassure that okay, your everything is all right, and you don't need to come to the clinic. But these functional causes for the pelvic pain, which will not be apparent in your laparoscopy, right? And also sometimes, so even you are during the laparoscopy, if it is and there is a, it gives a macros magnified picture, but still microscopic disease which can be missed, right? Another thing is every surgery, every operation carries the risk of post-operative adhesion, post-operative complications. These are there. So because of that reason, is laparoscopy also will be helpful in particular patient. But when you are selecting that, you have to think about your your patient selection is important, right? Patient selection is important. And another important thing is you should know that. So every patient, right? Every patient will not be required the surgery, will not require the surgery. Sometimes only thing is your reassurance and your talk to the patient, and your psychological reassurance is very, very important for these patients, right? So I'll show you a couple of gynecological problems for you all, just to have idea and and magnitude of this problem. So adenomyosis, one of the common and problem we can see in our pregnant and the female population. And so we can see edematous uterine wall with the deposition of your and endometrial tissues within the myometrium, and will give rise to cyclical or non-cyclical symptoms of pelvic pain. And also certainly your pelvic inflammatory disease can cause the pain related to the inflammation, right? So I'll show you, and one of the and video where we have recently did, and so how it's appear your adenomyotic appearance, right? Adenomyotic appearance. So you can see very and globular type of your womb and your uterus, and very bulky, and you can't see any other pelvic and pathology, and where your ovaries are normal, and you can see the your bladder and your bowel and everything is normal, but you can see the size of the uterus where and this adenomyosis is there. So obviously, and you can suspect on your diagnostic laparoscopy, but you only made the diagnosis if you are sending. It's a histological diagnosis basically, right? So and so another thing is, so pelvic inflammatory disease, you can see that how disturbed your pelvic functions with the inflammation, right? With the inflammation. So you can see that good example. So this lady came to us with the pelvic pain, and so eventually we found that, and so this IUCD was inserted long time ago, which was perforated uterine wall, and eventually it is in the bowel. And so that is the reason for the pain. And she came seek the help from the various places and came to us. And then we recently operated her. You can see that and how inflamed your pelvic environment and pelvic organs. And this was in the bowel mesentery, but not in the bowel. And so you see that. So how this type of things can cause exaggerated pain in the pelvis, right? So and apart from that, your endometriosis is one of the common problem, and one of the common problem you can find in the your and the reproductive age group population, and also and in the high incidence of prevalence of this problem in the patients with infertility, endometriosis. So endometriosis. And so you can see, I'll show you how much of disturbance to the your pelvis and pelvic functions with the endometriosis. And most of the time, this endometriosis is a hidden disease. It is asymptomatic most of the time. Sometimes you may have the problem and you are asymptomatic until the certain age of your life. Not everyone with endometriosis has the pain, right? So they will give rise the various type of pain symptoms related to all the pelvic organs, right? Maybe bladder pain, maybe the pain related to your bowel, maybe your uterine pain, cyclical menstrual pain, and so on. And also, and and not everyone with the everyone with the pain also, and it's not the reason is the endometriosis. And another thing is, even you are having very severe endometriosis, like deep endometriosis, where your severity of the pain sometimes not exactly related to the disease, right? Exactly not related to the disease. So, and sometimes, it is no, it's not correct, and more or less, and comparable with your disease process. And also, and pain mechanisms are multifactorial. It is not always just the disease or distortion or as a mass effect causing the pain. And sometimes this is a chronic inflammation is the reason making the pain for you all. Right, I'll show you this video and how it is, how disturbed this pelvis with the endometriosis. You can see that. So a complete destruction of your dynamic nature of the pelvis with the endometriosis, right? So you can see that large endometriomas arising from your ovaries, which is adhered completely your bowel, bladder, and whole pouch of Douglas is and obliterated. And also, and is basically these type of patients are chronically suffering, and chronically suffering, right? All the pelvic functions when they pee, right? When you're passing urine, it's very difficult, painful. When you have and defecation is a painful, and also, and sexual function is you can't think even, right? So, and they are greatly affected. So they're family, and the family and all the bonds with the partner and everything is affected eventually. And also, and eventually their quality of life is very, very low, right? Very, very low. So, and also they are coming to you with a very frustrated mind and they are seeking help for everywhere. So, but they are unable to get rid of this problem, right? Get rid of this problem. And also, and this is very much challenging to the healthcare professionals as well, and because and operating of this type of patient, or as more than the operation, coming to the diagnosis also challenging. And more than that is a challenge, when you are operating, and this type of operations is a morbidity is very, very high, and a lot of complication can be there. And even you operated, and so risk of complications are much higher, injury to your organs and relative organs like bladder, bowel, and all the vascular injuries and nerve injuries, and everything is much higher in these type of surgeries as well. So you can see that how this, and dynamic nature is disturbed during these diseases, right? So, and so apart from that, so, and apart from these three common things, so we can see some other, gynecology or two important condition: pelvic floor dysfunction. This is basically because of hypertonia or accelerated tone related to the pelvic floor. So where all the pelvic organs are rested, your bladder, your bowel, and your reproductive organs are resting on there. So if this high tone is there, so then this is act as a primary pain generator for you. And obviously it gives rise the pain during your sexual intercourse, and sometimes pain following sexual intercourse, and also sometimes chronic constipation, and and these type of symptoms. And treating and of this type of conditions is bit of challenging. It is difficult, right? It is difficult because there's no straightforward, and treatment modality available for them. However, there's some, and help you can get with the pelvic floor muscle physiotherapy. And also another thing is other disease condition often over, and we missed, and we are not thinking even pelvic congestion syndrome or pelvic varices, right? So this is it's a type of pelvic vascular insufficiency, and so where you can the patients are coming with a very dull, and pelvic pain, and progressively worsening, latter part of the day, and also and sometimes they will come and complain you postcoital pain, right? Postcoital pain, especially in the multiparous woman. Multiparous woman, where you can see that this type of, if the patients are coming with this type of history, if you excluded the other causes, sometimes it could be due to pelvic congestion, where again is the treating for these patients also challenging for you all. I'll show you this video, so how the appearance of your pelvic congestion syndrome, where you can see that so big, and dilated vascular system in the pelvis, and big vessels, and the venous congestion in the pelvis, what we call pelvic congestion syndrome, and pelvic varices can lead into the, the chronic pelvic pain. So in terms of management, right? In terms of management, you can see that chronic pelvic pain is due to multiple reasons. It's not due to, and it's a single reason related to the gynecology. And so obviously, if it is related to the gynecology, and so we also and always go with the multidisciplinary approach, not the management in isolation. So we need a lot of, and the pelvic pain team, right? Sometimes, physiotherapist, and also psychologist, importantly, and sometimes we need the help from the urologist. Like that is a teamwork. It's a teamwork. This concept has to be understand. If you are approaching this type of patient in the multidisciplinary way, so patient will be benefited, rather than, and you are just treating for the, and when you are seeing the patient for the chronic pelvic pain. So obviously, if you identify the patient reason for the chronic pelvic pain would be fine, you can manage. But if you are thinking overlapping conditions, and overlapping, and the pathologies for the pelvic pain, obviously you need an approach with the multidisciplinary team. And so this concept is very, very important. And also an other approach, when you are seeing that patient, if you are thinking this problem or chronic pelvic pain exclusively associated with your menstruation, or else it's a cyclical pain, so you can, one of the treatment approach what you can try for that this type of patient is a ovulation suppression. Ovulation suppression. So you can give the ovulation suppression for certain period of time, at least for 3 months, as a therapeutic trial. Then you can see the improvement after 3 months, right? Provided that they are not having any red flag symptoms, and that is very obvious. If the red flag symptoms are there, so you have to act rapidly and in the fast track. But so those things are not there. So then, one of the approach is the ovulation suppression, and with the different type of hormone. And also, and when it comes to the medical treatment, I'm not going to details, right? None of the medical treatment is, and none of the treatment is cure the problem. You can see that only treatment response is there, only 50 to 60%, and all the things below 60. So that is none of things reaching to the 100%, right? So because of that reason, even you are giving, identifying the pathology, and if you are giving these type of treatments, don't expect that 100% improvement of the symptoms. And also, you have to and warn the person or patient, and you have to say that is not going to cure your problem 100%, right? So we can help you up to certain extent only, and we'll see with the treatment, and then we'll do rest of the things depending on your response. That key message has to be passed. Otherwise, your patient will be frustrated, because and they are thinking that by giving your treatment, and their problem will be sorted immediately, right? So immediately. And and these are hormone and non-hormonal modalities, basically. And when it comes to the, rather than your medical management, so if it is indicated, only you can go for surgical management for the chronic pelvic pain. So where, if your diagnosis is the endometriosis, if you found large pelvic masses or cyst, if the adhesions are there, which is difficult to diagnose during your ultrasound scan, or else it's a failed medical therapy, right? If you are tried with the number of ways, medical management, if it is not responding or poorly responding, obviously next step is going to forward with the surgical management. Surgical management. But always, when you're offering the surgery, you have to think twice. Sometimes the problem will be aggravated as well. And also, and you have to explain that the complications of the operation very clearly and anticipated outcome as well. So, because otherwise, patient will think if you are offering the surgery, will 100% cure the problem, right? Cure the problem. It's not like that, right? So when you're offering this thing and your patient selection and identify the disease and very, very important, right? And also, so even you did the operation, you have to warn that your problem will be not sorted and maybe your pain will be persist following surgery. So you can see that these are the reasons why the pain can be persist even following the operation, right? Even after the operation, because this chronic pelvic pain already central sensitization, this phenomenon is there, and so because of that reason, they may have even pain in their mind, right? So more than the physical pain, and also pelvic floor dysfunction, where you can't address this pelvic floor and and increased tone, and if it is neuron related pain which is difficult to treat, and also if it is bladder pain and difficult to treat, and so if it's irritable bowel syndrome, and these are the type of condition very difficult to pain even after operation, you may persist with the pain. So because of that reason, so and if you are going for repeated invasive procedure, so you have to and very careful and very careful, and it is not always and beneficial for the patient, right? So when it comes to the future directions, and so in terms of the chronic pelvic pain, basically, and the advances are there for the diagnosis, like advanced imaging and some biomarkers and genomics. And the other important concept is a personalized medicine, rather than you are giving, treatment you have to give in the tailor-made treatment for the patient, so that you have to address the particular patient's problem and the particular patient's functional problems before, and consider the and certain type of treatment modalities. And also opioids, and you are using and very extensively, and these type of patients, they are addict to these things, and they are as they are using, and lot of tolerance is there. So because of that reason, when you are and giving opioids for this type of patient, they're very careful. And also, and we need to encourage non-opioid pain therapies for this type of patient. And other things for our setup, that, and as and our setup, when you are managing the patient with the chronic pelvic pain, it is very challenging because of our clinics are overcrowded, and we don't have much time to and allocate for them, and we don't have much time to talk to them. So because of that reason, and also resource limitations as well, so these challenges are there when you are working in the our system, and in terms of when you are addressing the chronic pelvic pain, right? And so key messages, these are very, very important. And and chronic pelvic pain is a multifactorial, right? Don't think that it is a only the single physical cause for this. And as we explained, it is a multifactorial and central sensitization, and it is and shared with the sometimes overlapping syndromes, and you may need to and share your treatments with the different teams. And also, and as a gynecologist, the message is, and we have to think beyond your gynecological pathologies as well for the chronic pelvic pain. And so I have highlighted basically what we can see in our patients, but so it's not always related to the gynecology as well. And the pain mechanism is matters, right? Pain mechanism you need to understand, right, before going for the treatments. And also, and the important key message is avoid the unnecessary operations or surgeries, because this is only for the selected patient, is not going to do the benefits for all the patients. And also, and rather than delayed multidisciplinary care, so it is important to address this problem and early, and in the multidisciplinary nature, right? So which improves the outcome. Patient may be satisfied, and that this type of patient seeking help from all the specialties, and they are frustrated. They are sometimes and the blaming nature most of the time, and when they comes to you with a lot of a story, and before the made the diagnosis, you have to and listen a longer time for them, and that sometimes cure the problem, right? So these type of patients comes to you. So, and because of these reasons, and so it is important to, and early involvement of the multidisciplinary team if it is indicated, and also and personalized medicine, or as and individualized treatment is and very useful in terms of addressing these type of pain syndromes. Okay, right. And so this is the end of the lecture. Thank you.